Okay, so I think I'm going to get started. It's 5 after 12, and I want to welcome everybody who's joining the webinar, the Medical Education Journal Club, which is a monthly offering through the Office of Academic Affairs and collaborating with the Medical Library at the Zucker School of Medicine. And as Vice President of Faculty Development for Northwell Health, I want to welcome you to our January webinar, which I've been planning for a long time with a wonderful speaker, Justin Sewell, and he is at the University of California, San Francisco. He's a gastroenterologist by profession, clinical profession, I should say, but he has also received a doctorate in medical education, and his thesis work for that doctorate was on cognitive load theory and procedure skills training. So it certainly connects to his clinical work, but is a very, very prevalent discussion in medical education today is cognitive load theory. So I saw his article published, I read it with enthusiasm and immediately contacted him. Would he lead the journal club for us versus asking somebody from Northwell to do that? And he said yes, so we're really excited because it's a journal club where the lead author is actually presenting their article, which is not always the case. Justin, could you please advance the slide for me? Just to go over some housekeeping, which seems to be always important. So the video is turned off. If you want to turn on the video, you can do that for yourself. Most people don't, but that's up to you. You have a picture of me as well as Justin Sewell, who will be one of the speakers, of course, after I finish. The audio is available through computer or phone, but if you're using the phone, we really would suggest signing in with an audio pin so we can identify you and send you post-session material. You are all muted because of background noise, which is very disturbing to people trying to listen, but you are able to unmute yourself if you want to speak during the discussion slides. There will be discussion slides. So you are definitely able to unmute yourselves. If there's any issue, we can unmute you as well. And just to be clear also, there is a chat box feature on the bottom of your screen. There's a chat box, and I will be monitoring the chat box to see if there's any questions or comments that you want to make. So if you want to use the chat box, please do that. Otherwise, we'll ask for discussion and you can unmute yourself or identify yourself and I will unmute you. The webinar is recorded for future viewing. I have lots of questions always. The webinar will be posted on the faculty development website with all the other Journal Club webinars, but you only get CME if you attend in person today. The CME does not relate to what's archived, which is one reason we need to know your name in order to also give you CME for the people who are using just a phone number to log in. I think that covers all the webinar and housekeeping. You'll hear from our medical librarian, Wendy Herman, after Justin. And we also have a discussant today, Allison Myers, who will be joining us and acting as discussant for the program and should be a really interesting. So Justin, I think you're on with the next slide.
All right, great. Thanks so much, Alice. It's my pleasure to be here. I'm good friends with John Young, who's in the Department of Psychiatry at Northwell, and it's really, I'm honored to be asked to discuss this paper. I thought we might start with a bit of discussion so you can, unmute yourselves if you'd like to answer these questions. I'm curious if anybody would recall and briefly share a recent experience in a clinical workplace environment where the learners appeared overwhelmed. Any burning examples of that?
I have an example.
Great.
Hi, everyone.
Identify yourself when you
Sure.
give an example. Thank you.
My name is Rodrigo Kong. I work in emergency medicine at Staten Island University Hospital for Northwell. I had a case recently with a learner, a PGY1. We were working in the critical care area, very busy shift. A patient had come in and had sustained multiple lacerations. They were superficial. They're very simple to repair, but there were a lot of them, and there were many other things that were happening in the emergency department. And for all of these different lacerations, depending upon what they were, the resident had to decide whether she would use suture, dermabond, steroid strips, multiple simple things, but there were many different decisions that needed to be made in the context of a very busy shift. And that happened just a couple of days ago.
Yeah, that's great. That's a great example. I mean, you've mentioned a couple kinds of cognitive load there that were contributing to that learner's overwhelmedness. So thank you for that example.
Sure.
Appreciate it. Is anybody on this call familiar with cognitive load theory?
Reminder, you would need to unmute yourself to speak.
Right.
It's Rodrigo again, only to the extent that I've read what was circulated.
All right.
That's a very good student. Thank you very much.
Appreciate it.
This is Mike Casara. I'm just joining, but yes, I've read a little bit about cognitive load through Dr. Young's work.
Great. Yeah, I honestly, a fair amount of what I know about cognitive load, I learned from John Young too. So we share that in common. Great. All right, well, let's get started. So I'll briefly review cognitive load theory, since that is the theoretical framework. Cognitive load theory is based on the Atkinson-Triffin three-mode model of human memory, where sensory memory and long-term memory are more or less infinite, but working memory is very constrained. During learning, the sensory memory is bombarded by all kinds of stimuli from our senses, and we use our working memory to decide which of these to attend to. The goal of learning then is to package these pieces, elements in working memory, into long-term schema that are then stored in long-term memory, and we are later able to retrieve for performance. There are three types of cognitive load, and Rodrigo mentioned a couple of them in his example. So the first is intrinsic load. This is the working memory that a learner needs to use to complete the task. So when your resident or your learner was having to do all these suturings or dermabonding of the lacerations, she was having a lot of intrinsic load, trying to decide what to do, how to do it, and then actually perform it. So we don't want intrinsic load to be either too low or too high. We want it to be matched to the learner's prior experience. Too high and they will be overloaded, too low and there's really nothing for them to learn. The second form of cognitive load is germane load, and this is when learners actually use that working memory to form or refine learning schemas. So doing the packaging of information, not just completing the task, but learning from it. And we want to promote germane load. And finally is the idea of extraneous load. This is when we use our working memory resources unproductively, like when we pay attention to distractions in the busy emergency department or other places. And so we want to minimize extraneous load. Put another way graphically, and the web reference is here for this figure. Here you can see this brain is just doing the task, doing the heavy lifting of all this information that it needs to know. In the middle, you can see that the brain is overwhelmed by a lot of things, and some of them seem important, like there's equations here, there's tools like calculators and computers, but if these are extraneous to the actual task of learning, they induce extraneous load. And finally, here you can see we have the brain juggling all these different things with facility and learning. That's germane load. So how does this work in the mind of a learner? If we consider this empty box, the working memory capacity for a learner, and it is fairly fixed for any given learner. Let's say a task involves this much extraneous load. Again, we're in this busy emergency department. We can't control that. And let's say this task that Rodrigo's learner was addressing was really challenging. Now her working memory is overwhelmed. There's too much cognitive load. Let's take the same, and overload occurs. So let's take the same learner, same working memory. Let's say we're in the workplace. We can't really control all that chaos. This learner is still going to have the extraneous load. But let's say that we take away part of the task from her and have her focus on part of the task. Now the task is easier. She has lower intrinsic load and hence leaves space for germane load. So that's the basics of cognitive load theory in a very quick nutshell. I want to see if people have questions about that. Does this seem relevant to your experiences as a health professions learner or teacher?
Remember, if you want to talk, you would have to unmute yourself. Which of these seem most relevant in your work? And identify your department that you're in so we have a little context when you speak.
This is Mike. I work in emergency medicine, yeah, I guess I can always get them confused. But I guess the germane load is the germane load is the one that I think sort of comes into play most when I'm working in the department and I have procedures with. When I'm working with residents who are trying to move through procedures, but they're sort of tasked with other things at the same time. I think it's I hope I'm speaking this correctly. I think it's also the one that I felt when we started the EMR at my place, when I was totally overwhelmed by just the workings of the EMR that I couldn't do other things at the same time. It was a procedure or just decision making or whatever. So I think it's totally relevant. Yes.
Yeah, the germane cognitive load is the one that seems to suffer the most, right? So when you're learning the AHR, when you have a busy ED and a lot of tasks to do, unfortunately for learners, oftentimes it's germane load that gets pushed out. Other thoughts on this or any questions? I know that's a really quick overview of a theoretical framework.
Okay. Elizabeth's hand is raised. Did you raise your hand, Elizabeth? No.
Yes, I did. I just don't want to create a feedback loop. My question was, in today's world, we have increasingly a noise environment by notification, by additional apps.
There's a whole echo.
Do you want me to stop?
No, I want you to turn yours off. She's moving. She's in the room with me, so it was just creating an echo.
Oh, I see. Okay.
Go ahead.
So thank you very much for these important topics. Me as an educator, I'm wondering if the environment that we currently work in, including notifications, new apps, new applications that we basically cannot select off, if they have an influence on our bandwidth, so to say, and what is your opinion on that? Thank you.
Yeah, that's a great question. I think they do. I mean, I think that all those things contribute to extraneous load. Extraneous load can be anything in the environment. It can be noise, distractions. It can be, Twitter updates, beeping on people's phones. It can be internal distractions. If people, when people get a text notification, they start thinking about the thing that their partner is texting them about. All these things can serve as a distraction and take them out of the learning environment cognitively. So I think there are multitudinous distractions in work-based learning environments. That's part of the reason I wanted to study them, is because the workplace is so much more complex than the classroom. So great. I want to make sure we keep moving along and have time for discussions. I think it sounds like we'll have a lot of people identifying with these concepts. I'm going to tell you very briefly about a first study because it sets up the main study that we're discussing today. In this study, our goal was, which was published in Academic Medicine, our goal was to identify from the perspective of experienced GI endoscopy teachers what kind of learning challenge they saw among their learners. We also looked at their teaching strategies, and we interpreted these in a qualitative study by considering cognitive load theory. And for reference, we interviewed 22 gastroenterologist surgeons and general practitioners who taught endoscopy, and about a third were women. These are and I realize I'm probably inducing cognitive overload with this slide, but we what we're really going to be focusing on today are the teaching strategies that they elucidated, that they felt helped their learners learn endoscopy. So for example, they talked about teaching along the developmental continuum, teaching simple things to early learners, more complex to later learners. Providing simple motor instruction. This is colonoscopy is a motor task. And so giving just, instruction, go up, go down, go forward, go back. Providing technical assistance, like helping with part of the procedure or even completely taking over. So these things would reduce, well, we hypothesize would reduce the task difficulty, the actual task itself, and so would reduce intrinsic load or match it to the learner's level. When they talked about ways to promote learning, they talked about teaching schemas or teaching complex concepts, trying to verbalize complex ideas that were being done during the procedure. They talked about, in the midst of a procedure, telling the learner to stop so they could listen and focus. And by stopping and not doing anything with their hands anymore, they would hopefully be able to focus on the teaching and again promote germane loaded learning. And they talked about having a mastery goal orientation. So a lot of procedural learners just want to be good. They want to be fast, but the teachers were trying to get them to focus on doing it well. And finally, they talked about ways to reduce those distractions and extraneous loads. So make the environment better, tell people to stop talking, tell people to turn off pagers, put them on buzz, on vibrate. They talked about system solutions like reorienting the curriculum so that learners have fewer competing demands. They talked about emotional support. So negative emotions can induce distractions and extraneous load. And so they talked about identifying with fellows' struggles and reassuring them. And finally, they talked about communicating expectations and roles. So if the fellow knows when the teacher will take over, that removes some of the stress about how well they're doing. Uh-oh, is my teacher going to take over now? So again, this is a qualitative interview study. We identified these teaching strategies, and our question then for the article for discussion today is, how will these teaching activities actually affect cognitive load? And I think in the interest of time, we will just get into this. Instead of asking how you would design a study, I'll talk about how we did ours, but I would love to hear your thoughts on how you would maybe do it differently afterwards. So the research questions we asked were, during sort of everyday endoscopy teaching, what teaching activities do faculty use and how do they enact them? Like, how do they actually do it? How do fellows perceive these strategies affect their cognitive load? And specifically, we were interested in whether activities that were meant to promote germane loaded learning did so. So here are the strategies that we looked at. We had to pick those that we thought would be observable. So for those we thought would make the task easier were motor instruction, technical assistance, and taking over. And these largely came from that prior study, which is why I told you about it. To promote germane load, we looked for checking understanding, so asking learners to tell what they thought instead of telling them what was happening. Giving feedback, promoting a mastery mindset, stop and focus, like I mentioned, and teaching schemas or complex concepts. And finally, to reduce extraneous load, we look for providing emotional support, setting expectations, and modifying the environment. We did completed a mixed methods study, which involved first colonoscopy observation. I observed teachers and fellows doing colonoscopy together and basically quickly, frantically on an Excel file, which fortunately I'm pretty quick at, recorded every time one of those teaching strategies occurred and what was said or done in paraphrases. After the procedure, we actually measured fellows' extraneous, intrinsic, and germane cognitive load using an instrument that I and colleagues, including John Young, had developed previously. So objectively assess their cognitive load. And then I interviewed each fellow and I asked them about each of those teaching activities that I observed. What did you think of this teaching activity? How did it help you complete the task? So that's intrinsic load. How did it help you learn from the task or not, either promote or interfere with completing the task, learning from the task, which is germane load, and avoiding distractions or staying focused, which is extraneous load. And then for our data analysis, we performed content analysis on those interviews and did a single correlation for germane load, which I'll show you. Again, I know this is really quick, but any major questions about the methods that we used, it might become more clear as I go through the results.
Once again, if you want to ask a question about the methods, it's a good opportunity now. Anyone? You'd have to unmute yourself. Okay, I think
All right.
you're clear, Justin. Great.
So I observed 10 colonoscopies, and you might feel that that's a small number of colonoscopies, and indeed it is a small number. But after 10, we reached information sufficiency. And for those of you who are not familiar with that term, it simply means we stopped seeing new things when I observed colonoscopy, stopped hearing new things with the interviews, and rather just kept having more of the same. And so we felt that at 10 observations it was adequate. These observations were performed on 8 fellows, so I did repeat observations with 2 fellows just because of limitations and numbers of fellows. But it was 10 different attending teachers. Overall, through those 10 colonoscopies, I observed 515 discrete instances of teaching that fit those teaching activities. And this may come as a surprise to no one, but this is the intensity of teaching. So on the y-axis, you have instances per minute procedural time of teaching. And so you can see it varied widely from, less than 1 instance of teaching per minute to more than 3 instances of teaching per minute of procedural time. And so that's a lot of teaching. And we learned a lot about these different patterns. So you have 4 that are, 1 that's a really major teacher, 3 that are in the middle, and then the rest are in the lower spectrum. So here are what we saw. We saw 215 episodes of motor instruction, which was by far the most common. Other very common ones included providing feedback, almost 100, teaching schemas of complex topics, checking learner understanding, and takeover. And so we had couched each of these under hypothesized impact. And actually for these most common, all of them met the hypothesized impact. So again, this was based on content analysis of interviews, but fellows routinely said, when my teacher told me what to do, it made the task easier, right? That makes sense. Like the learner no longer has to decide what to do, they just have to do it. Obviously, when my teacher took over, that made things easier because now the learner just stands there and watches. When the teacher asked me questions to probe my understanding, it helped me learn what they meant or what they were trying to teach me. So that's a way to promote germane load, is by asking probing and clarifying questions. When teachers provided feedback, it promoted learning. They reflected on what happened during the case and it helped me understand. And when the teachers attempted to teach complex topics or schemas, learners felt like this did indeed promote learning. So all 5 of the most common teaching activities did meet hypotheses for cognitive load impact. There were another 4 that were observed less frequently. And here it was kind of a mixed bag. So 2 of them did meet hypotheses. When the teacher helped with the procedure with parts, it made the procedure easier. That makes sense, right? And interestingly, when the teacher provided emotional support, it helped. So this was most often saying like, I can see that you're having a hard time. This was really hard for me too when I was in training. It's okay. And that removed that emotional angst and stress, which served as a distraction and helped the learner focus on the procedure. However, 2 other less common teaching activities did not meet hypotheses. So there are very few instances of the teacher modifying the environment, like asking people to be quiet or to, other things in the environment, and this really had no appreciable impact. And likewise, it didn't really seem to benefit the fellows when the teachers set expectations. They said, during this procedure, you're going to start. I'll help if you need help. If you're struggling, I'll take over. They didn't appreciate much impact. And finally, I actually observed no instances of these two teaching activities, even though they were discussed pretty widely in my qualitative study. That study was enriched for teachers with extensive educational insight and expertise. And so in these everyday teachers, we didn't see these teaching activities. Doesn't mean they're not valuable. It just means we couldn't assess their impact. Interestingly, we also did do some inductive analyses where we read through the transcripts and did observations to see what other teaching activities might exist that we hadn't planned to look for. And two of these came up. One that was very widely thought to promote germane load and learning was promoting autonomy. So this most often was enacted by the teacher taking a step or two away, like physically away from the learner, and just observing quietly. So instead of standing there and saying, you should do this, you should do this, you should do this, they just let the learner have their own process. And every single learner in which this occurred felt like it benefited them because they were able to have their own thought process, to see what worked, to see what didn't work, and understand the consequences of their actions during the procedure. So that was widely perceived as beneficial. The other activity that we didn't look for, but we found, was something that I labeled it cognitive information, and that was just the teacher provided little bits of information, like here we're in the cecum, in the colon, there's a polyp. It's just like little snippets, and these didn't really have any appreciable impact. I was very interested in studying germane load more rigorously, and you might argue that 10 observations and 1 correlation is not very rigorous, but it's more rigorous than a lot of other things that are out there, I'm just going to say, in terms of germane load. And so we ran a correlation where on the y-axis you have measured germane load using that instrument that we developed. It was performed immediately after the colonoscopy. And on the x-axis, you have the number of times, or number of instances of teaching activities that were found to promote germane load. So that is mostly these 3 activities, as well as the promoting autonomy. And so when we ran this correlation, you can see that there is, I think, a visual pattern here where there are more instances of germane load promoting activities. There appears to be greater germane load, and in fact, the Spearman's correlation did show a moderate correlation of 0.44. And remember, like, these shouldn't confound each other because this was my observation, which I didn't tell the fellow. I saw you're attending do 20 episodes of germane load promoting activities. This was my observation, and this was the fellow's completed instrument. So I really think that these activities promote whatever construct is being measured by my instrument, which I think is germane load. So I'm going to discuss some practical findings, and then we'll get into the discussion. So the main 4 take-homes that I learned to promote learning and procedural learning from the perspective of cognitive load theory is, number 1, to use teaching strategies judiciously. Really, when attendings just talked and talked and talked and did lots of teaching, it interfered with learning. So good teaching can be bad when it's used too much or at the wrong time. So one fellow said, when the attending gives too much instruction, I'm not given my own time to problem solve and figure things out on my own. So pay attention to when your learners are overloaded or not. If they look like they're overloaded, don't try to go into a complex discussion of pathophysiology. So second is teach when learners can listen, which is sort of what I just alluded to. When learners were busy doing lots of things, like Rodrigo's resident in the ER, if you start talking in detail to that learner about the finer techniques of suturing for a good cosmesis, when she's in the middle of trying to do all these things, she's not really going to be able to listen. So as an example, the fellow said, when the attending was asking me questions to clarify my understanding, it added to the distraction. I was still trying to figure out where the lumen was, and I wasn't at a place where I could think of other things. Thirdly is know your learner. Like, it's hard because, especially in certain fields, we're paired with different learners all the time. It's like I haven't seen you in 6 months. Like, what are you learning right now? Where are you at? And this went both ways. So the attendings taught things that were too complex that overwhelmed the learner. But as this fellow said, when the attending was teaching, I kind of know at this point already what they were saying. I wouldn't say their teaching was particularly helpful. So in the workplace, we have a lot more varied spectrum of learner experience. And so customizing our teaching to our learners' experience will help promote learning. And finally, as I mentioned, prioritize autonomy. Obviously, this needs to be developmentally appropriate autonomy, but learners really appreciated the chance to figure things out on their own. So this fellow said, almost the counter of fellow C, fellow J said, the attending basically granting me autonomy helped me learn. Doing it myself is the best way for me to learn how the scope feels. So, any questions about the results before we move on to limitations and discussion? Don't forget to unmute yourself.
I have a question.
Yeah.
It's Alice.
Yeah.
So thank you. That's so interesting. And I really appreciate how clearly you presented the results as well. So thank you very much. I'm not sure, Allison, are you on? Allison Myers? You would have to unmute yourself. Okay, I'm gonna sort of take over then.
All right.
One of the things, you use the word feedback as beneficial in the learning strategy, if I'm not correct. And that, I assume, was just-in-time feedback at the moment.
So it was a combination. But sorry, before, yeah. So
I'd love an example of what was characterized as feedback. And there's a lot of discussion in the feedback literature, which I'm sure, since you're a medical educator, maybe you're up on, about coaching as a feedback model. And were the comments that were made that you put under the Germain Load characteristic of feedback in the coaching context, language, or not?
Right, that's a great question. So I should have mentioned that. So there were two classes of feedback that I observed. One was what I call non-specific feedback, which was basically attending saying, good, all right, that's nice, excellent. No, it's just like these ongoing, it's almost like a sports commentator just like talking and talking. And fellows actually felt like that was a distraction. Like, they don't need general, good, nice, great. Specific feedback was much more helpful. So the times that fellows found it most helpful was after the procedure, when the attending would basically debrief the procedure. Here's what happened, how do you think it went, here's what happened, a feedback dialogue. This did sometimes occur during the procedure too. So the attending would say, the way that you went around that turn was right because blah, blah, blah. But usually it was post-procedural feedback that was perceived as most pertinent for promoting learning. Because I think that's the time when the fellows can listen, because they're not having to do the procedure at that time. They're just there to listen.
But it meant formatively?
It was meant formatively, yes.
And would you say that they were trying, so if it happened during the procedure, was that more coaching-like, and afterwards was more, traditional feedback, like things that went well, things that could be improved?
Yes.
Did you not see that coaching feature at all, or you didn't look for it? Maybe I'm putting words in your study, I guess.
Yeah, we didn't use that paradigm, but I think if you mean the feedback during the procedure was more often intended as directive to get the procedure done.
Of course, you had a real patient, so we, can't
Right.
be around too much.
Right. So, but I think it was most useful when it was provided after. Unfortunately, the post-procedure time period was not well used for teaching, even though it's the time where learners can listen and there's time for reflection. I think some of that's just, cultural here, where it's like, let's get on to the next patient. So that was one point that I brought up in the discussion is, we need to take advantage of these times when learners can actually listen.
Yeah, that's a very good point, and I'm going to give a chance for other people to ask some questions about the results, because reflection is such an important part of the learning cycles. And when you're doing a procedure, the reflection is not that strong because you're in the moment,
Right. Right.
But afterwards, that would be an opportunity, and if the faculty member encouraged that reflection, that might be fit into the germane load that's happening.
Absolutely.
Any other?
Allison,
Go ahead,
well,
Mike.
yes, I'm driving, but I'll try to get these out. Just two questions. When the faculty took over the procedure, did you observe any instances where they engaged in like a cognitive apprenticeship or like an annotation of what they were doing for the learner who was now vicariously watching? And then I'll just throw the other question quick is, were there any instances of pre-rehearsal or mental rehearsal before they actually engaged in the procedure?
Mm-hmm. Yeah, great question. So takeover was perceived as beneficial also for germane load when the attending would either dialogue what they are doing, or once the takeover period was over, they would say, well, how I got through that area of difficulty was X, Y, Z. So fellows, it's interesting because when I was a fellow, and I think still fellows today, there's just this burning desire to do it all yourself, and there's this sense of shame when the attending takes over. But the fellows in my study were quite reflective that actually, yeah, when the attending takes over, it provided me time to learn if, in fact, the attending did teaching. If the attending just did it and handed it back, then there wasn't much learning that occurred. So I would say that is in line with cognitive apprenticeship.
I think that's really an excellent point, Mike, the importance of cognitive apprenticeship if the learner takes over.
Mm-hmm. Yeah, absolutely. And so I try to encourage the fellows, if your attending's not telling you what they're doing, then ask them, like, what did you do? Why did you do that? Etc. And then, so the mental rehearsal question is interesting. I know that this is a common strategy that has shown benefit for surgery. I think, so I did not observe any instances of this. I think colonoscopy is somewhat less predictable than some routine surgeries because it comes to the challenge of doing colonoscopy. It's like a long, floppy instrument with limited, tactile sense, limited visual. All you get is a single 2D view. So it's harder to mentally rehearse because the steps are pretty simple. It's like insert the colon to the cecum, insert the scope to the cecum, withdraw, inspect, remove polyps. So the steps themselves are much simpler than like, a cholecystectomy or a surgical procedure. And I've also not seen any research on that for endoscopy in general. It would be interesting. It's interesting to think about whether that would apply to procedures that have only a few steps, even though the steps themselves are complex to enact.
Any other questions about the results? I have one more, but I'm going to hold myself back. Let some other people, if anybody else has any questions about the results. Well, people could think, because out of time, I'm going to ask this one. I'm a little focused on the set expectations in terms of decreasing extrinsic load.
Yeah.
You're saying that if they set expectations, that would decrease extrinsic load, or that makes people anxious? I just want to clarify.
Oh, sure. So in our because of that sense of wanting to do it all. So unlike most trainees doing surgery, until they're a senior resident, they're not going to do most of the surgery, right? There's always a surgical assist. A colonoscopy is a single operator procedure with a minor assist for like polyp removal or biopsy. And so a lot of fellows approach each colonoscopy like, I really hope I can do this whole thing without my attending taking over. And so it's always, so again, there's this sense of shame when the attending takes over. Some attendings take over really quick, some like let the fellow flounder. And so our hypothesis was if the attending tells the fellow, you know, during this procedure, I'll give you 5 minutes, 10 minutes, or I'll wait until I see you struggle, I'll take it, I'll try to give it back to you as soon as I can. It removes that ongoing mental angst about, is she gonna take over now? Is she gonna take over now? Is she gonna take over now? And would reduce extraneous load. We didn't see that, but that was our hypothesis.
Exactly what I was thinking, so I interpreted it correctly. I was just verifying.
Yeah.
I think setting expectations is helpful. Like, I'm going to give you a try once, but if and I think faculty don't do that enough from what I've heard from our learners in general, not just with what we're talking about now.
Right. Yeah.
People want to know what's expected of them.
Yeah.
Absolutely. And how things are going to go. It's a little bit of a roadmap. Anybody else have any questions about these wonderful results that were presented? They really cross anything you're doing. It's not specific to just this procedure. It really is applicable to a widespread aspect of medical education today. So please, if you have any questions and want to take it a little further, we have an expert with us. Allison, I know you joined. Thank you. I'm sorry if you're there, Allison. Do you want to add anything related to your work with cognitive load?
Hello?
Yeah, we can hear you. Go ahead, Allison.
Oh, hi. Yeah, so hello, everyone. I'm Allison Myers. I'm an endocrinologist, and I've been actually using the same theory, and I've talked to John about this, for my patients, because very often when we're providing patient education, we don't think about the fact that when we're teaching patients, they may have different needs, just like our students have different needs. So one of the things that we often use in the hospital is what's called the teach-back method. So by demonstrating first and then having the patient relay back what they've learned, usually can help decrease some of that germane load that John was mentioning earlier, and allow them to retain better what they really need to do when they get home, as opposed to just giving them a flyer, which is more of the traditional way that we used to do things. So one of the things that I've actually been trying to examine through research is if we give people an actual mobile application that, again, shows them what they've been doing in terms of their insulin pen technique, does that improve not only their cognitive load, but it does improve their technique and their glycemic control. So that's how I've tried to apply this theory to my own personal research.
And you say you've tried. How do you feel somewhat successful, or?
I'm waiting for the NIH to give me the blessing funding.
What about you personally, Alice?
I can tell you personally. So once the NIH comes through with money, then I'll be successful. But I can just tell you from our own small studies that we've done here, most patients don't know how to do it correctly, and that can obviously impair their ability to get good glycemic control, because if they're injecting no insulin, then their sugars will be high, and if they're injecting too much insulin, then their sugars would obviously be too low. So we have seen that in some of the little studies that we've done here at the hospital, but we want to do it on a larger magnitude, like I said, implementing an actual application, because typically, yes, we do the teach back here, but we send them home with flyers. We don't really send them home with something to reinforce this hand-eye coordination, similar to what, I was talking about today in terms of doing the procedure.
Yeah, you're basically promoting germane load. I mean, a teach back method is a way to promote germane load. When the learner, in this case, the patient's the learner. But when the learner puts things in their own words, that helps form schemas that can be stored in long-term memory.
Anybody else would like to add something? Thank you, Allison, so much.
No problem.
I think it's wonderful that you're trying to think about cognitive load, by the way, regarding patient education, because our ultimate goal is patient care and quality of care. And yes, teaching and learning is very dear to my heart, but if we could also help with patient education, I think it's a wonderful application. So good luck with your work. And I have no control over the NIH, but.
Thanks.
John, you want to go on, Justin?
Sure.
And then
So
Wendy will chime in.
sure. So there were numerous limitations of this study, which the medical education editors did want me to pontificate on extensively. So it's the longest limitation session I've ever written. We did this at a single university and only 2 institutions. I was the only observer, and I neither audio recorded nor video recorded, so it's all taking it on faith that I can keep track of everything that was happening. But as someone who's done endoscopy for almost 13 years, I felt that I could. Again, we did this in a single procedural field, and in fact, a single kind of procedure. But I've argued in a lot of my research that, at least for procedural skills training, GI endoscopy is a really good exemplar. It's like middle of the road, not as complex as a lot of surgery, and more complex, arguably, than a lot of bedside procedures. And I really think that the lessons we learned, I think the teaching strategies that we looked at are almost, besides motor instruction maybe, are generally applicable to cognitive settings as well. There was clearly a small sample size. 10 observations is not that many, but with qualitative research, you collect data till you don't need to collect data anymore, and that's generally that's what we did here. And finally, a big one is that we both did the interviews and measured cognitive load after the procedure. So these procedures were 15 to 40 minutes. And so cognitive load is going to vary throughout that procedure, and yet fellows had to give just one estimate of it at the end. And that can suffer from a peak and end effect. So the most memorable things are either really memorable things, like something that was really serious or mentally taxing, or end, meaning like the last thing they did. And so, there's really no way to measure the different types of cognitive load except with these sort of psychometric instruments with multiple items, which you can't do in the middle of a procedure. So there were limitations, but I felt that, nevertheless, I really, this was a unique contribution to the cognitive load literature, from what I could tell.
Okay, Wendy's on. Here she is. You want to
Hello.
camera you?
It's quite all right. I'll just go over the
Okay.
bibliometrics. For those of you who are joining our Medical Education Journal Club for the first time this year, I typically go over the metrics for the article that we discuss, and I take a look at traditional metrics as well as what's called alt metrics or alternative metrics. Due to technical difficulties, the traditional metrics that I typically look at through Scopus was unavailable for this particular article. It was citing some negative million citation backs, which obviously is not correct. So I'll be actually focusing on the alternative metrics today. So what you see here on the screen is the alt metric score, which essentially tells you how well the article is doing compared to similar articles within this field of research. This number is really dependent on the discipline that you're looking at. If you look just down below under the blue ring, it says this particular article was in the top 25 percentile of all research outputs scored by Altmetric. And then further below, it was mentioned by 12 tweets from 11 users, which equals to about over 16,000 followers. It's actually closer to 17,000 followers. And I actually like to really highlight that because it shows the exposure that the article gets just by a handful of tweets, really. So a lot more people have the potential of seeing the article compared to, let's say, the traditional method of either going to the journal website itself or through email blasts. Another thing that I actually wanted to highlight also is the readers on Mendeley. So literature indicates that the Mendeley numbers that you see here are actually more predictive in terms of having the article being cited back in a future article. So there are 10 Mendeley readers who have saved this article onto their library, which simply means that they've decided to select the article and put it in their personal library. I looked at the demographics, and what's really interesting is that a couple slides back, Alice had mentioned the widespread application of this particular article and its concepts. And if you look at the demographics of the Mendeley users, 10% of the users, which in this case would be one, but still is under the discipline of business management accounting. Others are mostly health sciences, medical sciences related, or veterinary sciences. But it does show that there are other disciplines that are looking at this article, or other professionals within different disciplines that are looking at this article that can be applicable to their line of work as well. Thank you.
Great.
It's always interesting.
It's so interesting. I didn't know there was so much in the score. I've seen these before.
Yeah, and unfortunately she didn't use Scopus this time, which gives more traditional information for whatever technical difficulty, but this altmetrics and, you know, the map shows where people are looking at this. Is this the
Yes.
accurate map?
Yes.
This is the live map.
Right.
What I find interesting, look at that top left corner. Who is looking at this? Take a look. Who's looking at this, Justin? Who are those people in that top left corner of the world?
You mean in the U.S.? In Alaska? Alaska's just big. Sorry. What do you?
Is that Alaska? No. That's Alaska up there.
Yeah. Yeah.
It seems amazing. I was thinking it was Canadian, but I don't see that.
Yeah, I was actually surprised. I mean, definitely, like, you know, there's a lot of meta research in Canada.
Yeah, in Canada. So
some cognitive load stuff, but
you want to go to the last slide, just out of time, and we put up some discussion questions. Allison, I know you went over patient education a little, which is very helpful to us, but I didn't know these other questions we have on the screen. I know some people are on phone only, so how might this apply to you? If anybody would love to share some thoughts, maybe some of the people who spoke earlier. Do you think there's other scholarly questions to ask regarding this type of work? Does anybody want to comment on this? Just out of time, I'm going to move people along. I know we had the earlier emergency medicine doctor from Staten Island. After thinking about the scenario you presented and the work that Justin presented, is there anything you would have done differently with that learner? I don't put you on the spot, but I just thought the case was really a perfect presentation.
Yeah.
I suppose there could have been a couple of things that we could have done. That getting anything done in the emergency department is often staffing and environmental challenges sort of preclude the ability to create the optimal environment for any learner. But in this particular learner's case, maybe it could have been possible actually to reduce her external load, the external cognitive load for the things that were going on around her. Maybe having this particular learner focus on only one or two types of problems that were involved in her field of problems. Also, maybe based on the article that we were talking about, maybe there could have been ways that I could have used different, if I could have spent time right next to her, then maybe there could have been things that I could have said to her, maybe like taking the time to go through, because before typically what happens is when you have a case like this, you might demonstrate for the learner how to do a couple throws, and then you have to step away to go do something else, and you check back in with them. But if I could have stayed next to her for a little bit longer and to give her a little bit more real-time feedback, so that she had a better sort of like a less distraction from if she was doing something right or wrong, that could have helped. So maybe narrowing the type of lacerations that I would have her do, do these first, and then I'm gonna come back and check on you. Then we do these. That might have helped her. And then also if I had spent a little bit more time next to her.
I really appreciate that self-reflection and self-assessment on yourself publicly on the screen here.
No problem.
So, but I'm thinking what you're saying is that we sometimes think by just showing one thing, okay, they're going to be able to do it. But this idea of this cognitive apprenticeship and being with them a little more, which of course everybody has such limited time, could be very helpful to the learner, because you walking away sort of jolts them as a cognitive load that, oh my God, I'm here alone. And oh my God, I can't make a mistake now. So you're actually, by walking away, increasing the load sometimes. Does that make sense, Justin, what I said?
Yeah, it does.
Okay, out of time, I want to be courteous. It's 1 o'clock. Could you go to the last screen, which is important for me? So I want to thank everybody. If anybody has a last comment, I'll give you another minute. Please, please, please do the SurveyMonkey. We need this data. Our next topic is coaching as a feedback skill. I brought that up, and I'm really excited. We have 2 presenters from our affiliate hospital of Long Island Jewish Medical Center at Forest Hills. I hope I got that right. And both of these people are really excited medical educators. And if you have any interest or want to contact me about anything on that, the next journal club is Wednesday, February 26th. So we have a little bit of time. I'll be sending PR and registration out. And you will get the PowerPoint from today's presentation if we have something beyond your telephone number, for sure. And I'd like to thank Justin for doing an amazing job early in the morning in San Francisco. And any closing remarks, Justin, and we'll be done.
No, I really appreciate the opportunity to present and everybody's attention. If you find that you're just totally fascinated with cognitive load, you can feel free to talk to your and my colleague John Young, or if anyone really wants information, I have a thesis PDF copy I can send you. So feel free to reach out if anyone's interested. Okay,
great. And everybody have a great afternoon. And we had a pretty smooth operation here today. Thank you, whoever set that up. Okay, bye-bye.
Bye-bye, thanks.